I want to tell you about Margaret. She was 68, sharp as a tack, did the crossword every morning, remembered every birthday in the family without checking a calendar. Her daughter called her the human Google of our household. Then, about 18 months after her doctor added a new prescription, her daughter called me in tears. Margaret couldn't remember what she'd had for breakfast. She was getting lost driving home from the grocery store she'd visited every week for 20 years. She repeated the same questions 3 times in one conversation. Her neurologist suspected early Alzheimer's. Her family was devastated, but here's what nobody told them. Margaret's dementia wasn't Alzheimer's at all. It was her medicine cabinet. When we reviewed her medications and made strategic changes under her physician's guidance, Margaret started coming back. Within 4 months, she was doing the crossword again. This is not a miracle story. This is preventable medicine. Today, I'm going to walk you through the 9 most common medications that could be quietly, invisibly stealing your memory, ranked from commonly overlooked all the way to the most dangerous pattern most doctors never warn you about. I'm Dr. Markus Dexter, and stay with me to number 1, because number 1 isn't a single medication. It's a hidden pattern affecting millions of seniors right now, and almost nobody is talking about it. Before we go through this list, I need to be clear. I am not telling you to stop your medications. Please do not do that without speaking to your physician. What I am telling you is that you have every right to ask questions, to understand what's going into your body, and to advocate for the health of your brain. Knowledge is not dangerous. Silence is. Drop a comment below right now. Are you over 60? What medications are you currently taking? I read every comment, and your experience might help someone else watching today. How many of you have a bottle of Benadryl in your nightstand right now? It's cheap, it's over the counter, it says sleep aid right on the package. What could be more harmless? Here's what that little pink pill is actually doing to a brain over 60. Diphenhydramine belongs to a drug class called anticholinergics, and that word is going to come up again and again in this video, so remember it. Anticholinergics block a neurotransmitter called acetylcholine, the brain's primary messenger for forming memories, maintaining focus, and staying alert. When you're young, your brain has plenty to spare. Over 60, you're already running on a lower baseline. Block more of it every night, and the impact is significant. A landmark study in the Journal of the American Geriatric Society found that older adults using diphenhydramine regularly faced a substantially elevated risk of cognitive decline, with measurable shrinkage in memory-related brain regions on neuroimaging. It also hides in dozens of products you don't think of as antihistamines. Anything labeled PM, nighttime relief, or sleep formula almost certainly contains it. Better alternatives. For allergies, ask about second-generation antihistamines like loratadine or cetirizine. They don't cross the blood-brain barrier the same way. We'll talk safer sleep options at the end. Raise your hand if you've been taking an acid reflux pill every single morning for years, and no one has ever suggested you try to stop. PPIs are one of the most overprescribed medication categories in the world. Most were designed for 8 to 12 weeks of use. Millions of seniors have been on them for years. The problem: your stomach acid also extracts and absorbs vitamin B12 from food. B12 is not optional for brain health, it's essential. B12 deficiency is clinically linked to memory impairment, depression, and a pattern of cognitive decline that so closely mirrors early Alzheimer's. The two are sometimes confused even by experienced physicians. A 2016 study in JAMA Neurology examining over 73,000 adults found that long-term PPI users had a 44% higher risk of developing dementia. Research has also linked PPIs to accelerated accumulation of amyloid beta plaques, the toxic protein buildup that defines Alzheimer's disease. Talk to your doctor about tapering off using H2 blockers like famotidine as a bridge. And if you stay on PPIs long-term, get your B12 and magnesium checked regularly. Overactive bladder is a real issue. It disrupts sleep, it's embarrassing, and when a doctor prescribes oxybutynin, of course you take it. What almost nobody explains is this. Oxybutynin is one of the strongest anticholinergic medications in common clinical use. It doesn't just work on your bladder. It crosses the blood-brain barrier with remarkable ease and directly interferes with the same acetylcholine systems responsible for memory and learning. Studies have shown that the hippocampus, the brain's memory filing center, demonstrates measurable volume reduction in long-term anticholinergic users. We're talking about a physical, structural change, brain tissue. A 2019 study in the British Medical Journal found that seniors using strong anticholinergics like oxybutynin for more than 1 year had a 49% higher risk of dementia diagnosis. The early symptoms, forgetting appointments, misplacing objects, losing words mid-sentence, are almost always chalked up to normal aging. the medication never gets questioned. The good news, newer bladder medications like mirabegron work through an entirely different mechanism and carry dramatically less cognitive risk. If you're on oxybutynin and you've noticed mental changes, have this specific conversation with your doctor. Dr. 6. Benzodiazepines, 520, 620. Benzodiazepines, benzos, have helped millions manage severe anxiety, panic attacks, and sleep disorders. I am not dismissing that, but hear the science. Benzos amplify GABA, your brain's natural calm-down signal, remarkably effective short-term. The problem is what happens when that mechanism stays switched on for months or years. A 2022 study tracking over 8,000 seniors found that those who used benzodiazepines for more than 3 months had a 51% increased risk of Alzheimer's disease, highest for long-acting formulations like diazepam, which accumulate in fatty tissue, including brain tissue, over time. When GABA is chronically overamplified, the brain reduces its own natural activity, neuroplasticity deteriorates, memory encoding slows, and the trap, when you try to stop, withdrawal can be brutal, making the drug feel necessary even as it's causing harm. Never stop benzodiazepines abruptly. Work with your physician on a slow, supervised taper. Alternatives include buspirone for anxiety and cognitive behavioral therapy for insomnia, CBTI, for sleep. Statins genuinely save lives. For many patients, they are appropriate and important. But here's what your cardiologist may not have told you. Your brain is nearly 60% fat. Cholesterol isn't the villain. In the brain, it's a structural necessity. It forms the myelin sheath that insulates your nerve fibers, and it's essential for forming synapses. Without adequate cholesterol, neurons struggle to communicate. The FDA updated statin labeling in 2012 to include warnings about memory loss and confusion, after reviewing thousands of adverse event reports. Not all statins carry equal risk. Lipophilic statins like simvastatin and atorvastatin cross the blood-brain barrier more readily. Hydrophilic statins like pravastatin and rosuvastatin have shown significantly less cognitive impact in comparative studies. If you're experiencing brain fog on a statin, ask your doctor about switching to a hydrophilic option and have your CoQ10 levels checked. Statins deplete this compound, which is critical for cellular energy in the brain. This one surprises people every time, because amitriptyline is often prescribed for things that seem unrelated to psychiatry: nerve pain, chronic migraines, fibromyalgia, insomnia. But amitriptyline is one of the most potently anticholinergic medications still in widespread use. Its interference with the acetylcholine system is stronger than many drugs developed specifically as bladder medications or allergy treatments. A landmark 2015 study in JAMA Internal Medicine examined over 3,400 adults aged 65 and older over 10 years and found that high cumulative anticholinergic exposure with amitriptyline among the top contributors was associated with a 54% greater risk of dementia, and the damage wasn't dramatic. There was rarely a clear warning sign. Just a slow, creeping erosion, word-finding difficulties, trouble sequencing tasks, and inability to hold complex thoughts, all attributed to normal aging for years before anyone looked at the medication. Alternatives: duloxetine or gabapentin for nerve pain carry far less anticholinergic burden. For sleep, low-dose doxepin in very small amounts has a more favorable profile. For mood, modern SSRIs are significantly safer for aging brains. Pay close attention to this one. What I'm about to tell you happens every single day in nursing homes and memory care units across this country, and most families never find out. Antipsychotic medications were developed for serious psychiatric conditions, schizophrenia, bipolar disorder with psychosis. But today, they are routinely prescribed off-label to elderly patients who are simply confused, restless, or agitated. Not because they have psychosis, because they're inconvenient. I'll say that again. There are seniors in long-term care facilities right now being sedated with antipsychotic medications, not for their benefit, but for the convenience of understaffed caregiving environments. The FDA issued a black box warning about this practice over a decade ago, citing increased risk of death in elderly patients with dementia-related behaviors, and yet the prescriptions continue. A 2022 study in The Lancet Healthy Longevity tracking more than 25,000 older adults found that seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months, even with no prior dementia diagnosis. If a loved one in a care facility is being prescribed quetiapine or risperidone for reasons other than documented psychosis, ask why. Ask what the plan is to stop. Ask what non-pharmaceutical interventions have been tried. You are entitled to those answers. This one doesn't get nearly enough attention. Paroxetine, sold as Paxil, is classified as an SSRI, the same family as Prozac, Zoloft, and Lexapro. And when people hear SSRI, they think safer antidepressant, modern, better tolerated. That's true for most SSRIs. Paroxetine is the exception. Unlike every other SSRI, paroxetine has significant anticholinergic activity. While Zoloft and Lexapro leave acetylcholine largely undisturbed, Paxil interferes with it in a way that much more closely resembles the older tricyclic antidepressants. A 2021 review in Frontiers in Psychiatry found that elderly patients on paroxetine showed measurable declines in short-term memory and verbal recall within the first year, declines not seen in patients on other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on their Beers criteria, an official list of medications considered potentially inappropriate for older adults. The frustrating part, paroxetine is frequently prescribed to older adults for anxiety and depression, the very population it poses the most risk to. If you're on Paxil and you're over 60, ask your physician whether switching to sertraline or escitalopram might offer equivalent benefit without the anticholinergic burden. We've made it to number 1, and I told you at the start this wouldn't be a single medication. Every drug on this list, taken alone, might cause only mild cognitive effects in some people. A little more brain fog, a little more forgetfulness, easy to dismiss, easy to blame on age. But here's what happens in the real world. Seniors don't take one medication. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, 10 or more, a combination of prescriptions, over-the-counter products, and supplements, often from multiple doctors who don't have full visibility into each other's prescribing. When several of those medications carry anticholinergic properties, they don't just add together. Research suggests they multiply. A 2022 analysis in Age and Aging tracking over 280,000 older adults found that those with the highest anticholinergic burden had a 120% increased risk of developing dementia over 10 years, double the risk, from pills that most of them had never once been warned about. Let me make this real. Imagine a 70-year-old woman, let's call her Dorothy. She takes diphenhydramine PM every night to sleep. She takes oxybutynin for her bladder. She was recently prescribed amitriptyline for nerve pain, and she takes an over-the-counter heartburn pill every morning. 3 of those 4 are anticholinergic. Each one, according to her separate prescribers, is appropriate and safe. Together, her anticholinergic burden score may be in a range clinically associated with significant dementia risk. And not one doctor, not one pharmacist has done the math on her behalf. This is not a hypothetical. This is Dorothy. This is Margaret. This is your neighbor, your mother, your spouse. The medical term is anticholinergic polypharmacy, and it may be the single most underreported driver of dementia-like symptoms in the elderly population today. Here is what I need you to hear clearly. Drug-induced cognitive decline is often reversible. I have seen it personally. When the medication burden is identified and systematically reduced under proper medical supervision, many patients experience a remarkable return of mental clarity. Memory returns. Personality reemerges. The fog lifts. Your brain is not a passive organ. It is adaptive, resilient, and capable of healing when given the conditions to do so. Here is your 5-step action plan, starting this week. Step 1. Write down everything you take. Every prescription, every over-the-counter product, every supplement, every sleep aid. Don't leave anything out. Step 2. Look up the Anticholinergic Cognitive Burden Scale, the ACB scale. It's a free, publicly available tool that scores each medication by its anticholinergic risk. A simple web search will find it. Step 3. Schedule a medication review with your primary care physician. Use those exact words. I'd like to schedule a medication review to assess my anticholinergic burden. A good physician will not be offended. They'll appreciate the advocacy. Step 4. Ask specifically about deprescribing, the intentional, supervised process of tapering off medications that are no longer necessary or carry unacceptable risk. It is a legitimate and growing field of geriatric medicine. Step 5. If your doctor is dismissive, get a second opinion. You are not being difficult. You are being responsible. A geriatric pharmacist, yes, that specialization exists, can also perform a comprehensive medication review. Before you go, I want to hear from you. Which of these 9 medications are you or someone you love currently taking? Have you ever noticed brain fog, memory lapses, or confusion and never once connected it to a medication? Have you had a doctor dismiss those concerns? Tell me in the comments. I read them. This community reads them. And sometimes the most important thing is simply knowing that what's happening to your mind isn't inevitable, and it isn't your fault. If this video helped you today, please share it. The person who most needs to see this probably isn't going to search for it on their own. You might be the reason they find it. I'm Dr. Markus Dexter. Your brain is worth protecting, and now you have the tools to start. Stay sharp, stay informed, and I'll see you in the next one. This video contains general medical information based on published research and clinical experience. It is not a substitute for personal medical care. Before making any changes to your medications, please consult your own physician first.